My name's Tim Nutbeam, and I'm hopeful now that you can see a screen which says critical decision making in extrication. It's really nice to be here. I've known Keith Porter, who's heavily involved with trauma care since I was in fact, since I was a medical student. And it's really nice to be able to dip back many years later and support the charity in work like this. My background is in emergency medicine and pre-hospital emergency medicine, and I've worked on air ambulances since around about 2007, and since that time have developed an interest in extrication and worked with some people on this call, particularly Mike, who's going to help me with any difficult questions later on, who's got a fire and rescue background, the Road Safety Trust, the Parliamentary Advisory Group for Transport Safety, the National Fire Chiefs Council, and many others in trying to help me understand extrication and also understanding that kind of that careful link where kind of medicine and clinical and extrication comes together. It's really great to see all the people who are there and all your different backgrounds. I feel a little bit like speaking into the void. I'm sat in my my office at home, which is also cold without heating, and it's good to see that chat's there. So please keep the chat up. Let me know any questions as we go along. I'll keep an eye on it. I'm sure I'll get moderated as well. So please jump in. So I was given this title by Keith and asked to talk about critical decision making extrication, and we're going to talk a bit about decision making, and we're going to talk a bit about extrication and how they come together, and what I've learned about decision making and extrication over the last few years. And hopefully this will work. I've written it just for this evening, so fingers crossed it will all work. But I'll appreciate your feedback, and hopefully it will be useful in your practice. So, critical decision making extrication. So this used to be super easy. So in the olden days, we read a textbook and it told us what to do, and it was extremely binary and extremely black and white. When you trace the history of extrication, which is kind of runs hand in hand with the history of vehicles and runs hand in hand with the history of immobilization, you see statements like this starting to crop up in textbooks in the 1980s. So the presence of spinal injury must be assumed with sudden acceleration or deceleration. And with an unstable fracture or dislocation of the spine, displacement for as little as 1 millimeter, they're enough to compress, pinch, or shear the spinal cord. And these statements actually became mantra, and you see them throughout the orthopedic literature. You see them in the original advanced trauma life support courses. You see them in fire ops manuals throughout the world, and you see them again and again. And everyone followed this mantra. And through medicine, when we did our ATLS courses, it used to be called ATLS hands, where the first thing you ever did when you clamped ties on the patient was you checked the scene was safe and nothing was going to fall on you or get electrocuted, because some of the scenarios were pretty bizarre. And then you'd put your hands on their neck and stabilize it. And it's really interesting when you go and spend some time looking back through this data and working out where these statements come from. They're what we call zombie statistics. So the references take you back to something where someone has either misinterpreted the data which is in front of them, or they've relied on expert opinion, or perhaps even kind of just made it up is too strong, but put some numbers there which you find really hard to either replicate or find are kind of linked to the true number of cases. When I started my journey of interest in extrication, I assumed that things used to be different, and now we were seeing things as we were with modern cars and seat belts and all those sorts of stuff. As I said, I've only been involved in pre-hospital care since kind of the mid-2000s. And I assumed back in the 70s and 80s and 90s that things were very, very different. And as a result of modern cars, as a result of safety systems, that we'd seen a change in the patients and seen a change in the trauma. So perhaps neck trauma and spinal trauma used to be really common, and that's how we ended up with extrication as we do. actually, when you start digging about in historical libraries and spending time looking at OHP slides and looking at historical documents, you find that that isn't actually the case. And spinal injury has never been a big cause of excess morbidity following motor vehicle collisions. And actually, most of the morbidity, as it is nowadays, is generated by head, chest, abdominal and pelvis injuries rather than spinal injuries. And those have always outnumbered spinal injuries by tens, 20s to 1. So it used to be really simple. And over the last 10 or 15 years, we've seen practice change, and we've realized that those statistics were zombie statistics, and we've realized that they probably don't apply to our everyday practice that we see. And the clinicians, and there's many of them on this forum, have realized that things aren't as we're taught, and perhaps some of the mantras, a millimetre of movement is going to cause us big problems, don't make sense if someone's bleeding to death because they've avulsed their kidney. So we realise that they don't really apply to our patients, or they're difficult to apply in practice. And then kind of over time, I've seen it definitely over the last 15 years, and I've been involved with this before, definitely been involved with this, is part kind of this very binary decision-making around, collars were great and now they're terrible, or spinal mobilisation was great and now we don't need it anymore. And actually, the more I've learned about the subject, the more I've realised that this is about complexity, and that binary, yes, stick a collar on them, or no, burn all collars because all collars are terrible, just doesn't work for our patients, and doesn't work for the patients we see in front of us, and doesn't help us minimise excess morbidity and mortality, which is all we are about. We've also started to see some of these in our practice, and if you pick up a copy of JR Calc, if you pick up an ATLS manual, if you pick up any of the guidance, you'll see lots and lots of things like this. And effectively, algorithmic decision making isn't really decision making. You're following a tree. You're not using much in terms of your clinical nous and interpretation, and you're just kind of doing what the boxes say. And that's not really decision making in my book. That is following an algorithm. And actually, these algorithms, they're often poorly designed, and they're often kind of bastardized from other backgrounds. So if you look at the Canadian C-spine rule and Nexus, these were all about imaging. So these were derived from large data sets to tell us which patient might have a spinal injury. That's very, very different from the patient group which might benefit from immobilization. Not all spinal injuries need immobilization, and some of them might actually not benefit from immobilization. So taking something which is designed to tell you who to image, or help you make a decision about who to image, and apply it to immobilization is a bad idea. It's a different group, and this, once again, this isn't decision making. This is following an algorithm. So we get to the situation where we've got a problem, and the problem is complexity, and the problem is that there is so many different factors affecting the best route of extrication, or what we might do for our patients, or where we do that for the patients, or what we do in vehicle versus out of vehicle, or what analgesics we use, or what clinical examination we do, or what route of extrication we take, that it becomes incredibly complex, and you can't capture that in an algorithm like we saw previously, and it all gets a bit difficult. Now, I'm hoping for some degree of audience participation here, and it might fall completely on its face, but I've come up with a couple of things which would make a difference when planning my extrication and clinical strategy, kind of like intra and immediately post extrication. So I've put two here. So the patient's age is going to make a difference, because I know frailty trauma is different, or seems to be different from other trauma, and the injuries that I suspect are going to be different. Now, what I'd like, there's 100 or so of you out there. Can you come up with other things which might affect your decision making? Stick them in the chat. It'd be really good if someone did put level of consciousness. I like it. Let's follow on from that, and let's put a few of these in the chat. What might make a difference? Perfect. I hope we're all keeping an eye on the chat, because there is many different suggestions there. So alcohol intoxication, comorbidities, lots of scene stuff, scene safety, how sick they are, whether we believe they've got time critical injuries, and we'll pick up on that later on. Risk of not getting them out as soon as assets available, great. Security situation in Mali, I can understand that. I've got friends out in Mali at the moment. Mechanism and loss of consciousness, pregnancy, yeah, all brilliant things, and very similar to your list. I came up with a list of bits and pieces, and you could write a list which had 50 or 100 of these things on. I've got age, frailty, position in car, availability of resources, where the impact is, has there been a transfer of energy, use of safe systems, ability to self-extricate, many different things. And the problem is, if you try to capture that into an algorithm so that I could arrive on scene and get out my little book and follow it through and work out what the right thing to do with this patient is, it might look like something on this chart. And at the point that things become that complicated, they become pretty useless to us in a challenging environment, which is pre-hospital care. So we need something better. And I was Googling decision making in complexity and trying to come up with some decision making algorithms that could teach you, or decision making tools that we could use together to help use some of these ideas we've got down the left hand side, and all those that we've got in the chat, and apply them to the problem of extrication. As I said, I was given this topic to talk about, so I went away and did my research, and I found it really difficult to find something which was useful. This was one of the first things that popped up on Google, and I initially threw it in the bin and looked at other decision-making tools from the business literature, particularly from things like the Harvard Business Review, about how we analyze, about how we take things in, about how we consider alternatives and how we move forward. So there's many decision-making models based on that. But actually, I came back to this one because actually I think it kind of represents the situation on scene, in that we're often got a confusing story. We've often gotten the confusion around what the mechanism's been, what the transfer of energy is. We're often confused in terms of what the clinical signs are and how to interpret them in the context of the very complex patient in front of us. And then we have this great decision-making machine, which is meant to be us. This is you. What the output we're looking for is some sort of clarity. So I thought what I'd try to do is use my experience of researching this area and spending some time in this area to help with some of those elements of confusion. Now, there's 3 arrows there, and I'm going to help you with 3 aspects. But in reality, there's 10, 20 aspects. But I'm going to do my best to help them with 3, and hopefully that will give you some clarity when you're making decisions on scene, or at least help you with some of these really complex and difficult decisions that we face. So I'm going to talk to you about the frequency and type of time critical injuries and spinal injuries that people who are trapped in cars have. I'm going to talk to you about what the patients want, what their experience of extrication is, and what's important to them as they're trapped in their cars. I'm going to talk to you about some of the biomechanical research that I've done with the National Fire Chiefs Council, with Mike, who's on this call, and supported by the Road Safety Trust, and talk to you about some of the outcomes from that research, which probably challenges some of the paradigms that we believe in around extrication. So we're going to take each one of those one by one, spend a bit of time on them, and we'll see what we find. So the first one, looking at time critical and spinal injuries. I've done some research with some excellent colleagues on this area, and I'm hoping if you hold your phone to your screen, that QR code on the right will take you to this paper, which is free and open access, which means you can download it for free. It's not full of viruses, and you will be able to read the full length of this paper and see what we got up to. I apologise. When I was copying and pasting these papers, I realised just how horrible the titles of them were. So I apologise for the length of the titles. They don't really do the papers justice. But anyway, the very, very long title tells us what this paper is about. And it's about looking at the injury patterns and outcomes for patients injured in motor vehicle collisions and comparing two groups, those who are trapped and those who aren't trapped. And this was supported by the Trauma Audit Research Network, which is an excellent organisation based in Manchester, and they collect data from trauma centres and non-trauma centres. So they do a really good job of capturing all the injured population, particularly the moderate and severely injured population in England and then elsewhere in the UK. And there's also a Eurotarn database as well, which helps inform them. And what we did is we looked at all patients who were injured in the motor vehicle collisions. We split those into those who were trapped and those who were not trapped. And those who we didn't know, we effectively put those patients in the bin because we didn't know which group they'd fall into, and it wouldn't help with our comparisons. And then we compared these groups, and you'll see what we learnt about them. So we found that a majority of the patients who were trapped were male. But if you look at the number, is more equal in the trapped versus non-trapped. So trapped is on the left, non-trapped is on the right. We found the ages were equal, kind of between trapped and non-trapped patients. The injury severity score, so that's that ISS you see in the kind of fourth row down. That's the injury severity score. The higher the number, the more likely the patient is to die. So people who were trapped were more injured than people who are not trapped. Which of course those of us who attend these patients know, but it's not been demonstrated before. Interestingly, despite the difference in injuries, and we'll dig into that a bit later on, the blood pressures were the same and very normal. The respiratory rates were the same and only a little bit high. The oxygen saturations were the same, and the GCSs were effectively the same. So despite differences in outcome, the clinical observations don't tell us a huge amount. We'll pick up on this in more detail. We've got time later on, but it's interesting when we've done this, looking at different groups and looking at the well and the moderately injured and the severely injured, is that clinical observations really don't perform very well at all at identifying people with major injury. They perform well at people who are mega sick. And, if you've got a heart rate of 150 and a blood pressure of 20, you're really, really sick. But you know what? You didn't need a set of observations to tell you that. You can see from the end of the car, you can see from looking through the window that patient's in a terrible state. And actually using clinical observations to work out who's moderately sick and who's very sick isn't going to be hugely useful, unfortunately. And every time we look at things like shock index, recording lactate, looking at heart rates, looking at blood pressure, looking at respiratory rate, they do, once you get into the very, very sick category, they perhaps have some utility. But determining, particularly when we've got an unclear time zero on when the injury was, how sick a patient is, they're not very useful with that at all. And at the end here, we can see that the crude mortality was higher in those who were trapped. And so what we did is we created the model and did an analysis to see, once we took into account things like age, comorbidities, their injury severity score, their frailty, and worked out what the difference was between trapped and non-trapped patients, and that's this WS score here. Would there be a difference? And effectively there is. So even once you account for all those known confounders, trapped patients are likely to have a poor outcome compared to untrapped patients. So that means if you've got a patient who's trapped and they've got an identical age and background, etc., and you've got as a patient who is untrapped, that patient who's trapped will do worse just because they're trapped. And even though that makes sense to a lot of us who've spent time with these patients on scene, that's not been demonstrated before that there's excess mortality. The good thing about that excess mortality is it probably means that we can do something about it. This is a separate paper which hasn't been published yet, but looks particularly at the issues with age and trapped status. And we can see here, this red line is the mortality of patients who are trapped, once adjusted for all the things that we talked about before. And this is the untracked group. And you can see that these lines separate out quite significantly as our patients get older. So older patients particularly are more likely to die if they are trapped, and that group requires special care and attention. I can see in the chat, yeah, compensate, crash, yeah, that's that's exactly what occurs. And my man, you know, everyone needs to come out quickly because you want to catch them in the compensation phase rather than the crash phase. So thank you for that, Chris. So this slide looks at the injuries of time critical injuries from spinal injuries by trap status. And actually, we can see that there are significant differences, so very low p-values between them. But if you look at the clinical differences, even though there's differences because the numbers are so high in terms of the number of patients we looked at, actually, you know, 1% versus 0.7, not a big difference. 3.5 versus 1.9, probably not a big difference. And if you work your way down, there's no, even though there's statistically significant differences between the group, with always the trapped patients being more injured at these time critical and spinal injuries than not. Actually, the numbers between the group are probably not clinically significant when you're looking at a car full of 4 people in front of you. And interestingly, when you look at these numbers of spinal fractures, so not all spinal fractures are created equal. The spinal fractures we're interested to are the ones which are going to deteriorate due to minor or moderate movements. And those are your unstable spinal fractures, so this line here, and those patients with cord injuries. And those are the ones who theoretically a moderate or minor injury may, and there's lots of argument discussion around this, cause further or contribute to secondary cord injury. And you can see that as a percentage of all extrications, this is a very, very small group. So 1.46 of all extrications, or 0.7 with a cord injury. So effectively, this group here, 1.46 and 0.7, are the only ones who can benefit from our current extrication strategy, which is based on spinal immobilization rather than rapidity, whereas every other patient is probably going to be harmed by that. Once you dig down into these patients as well, more than half of them have actually got a more important time critical injury. So the principles of looking after someone's spinal cord are to maintain their blood pressure, look after their secondary injuries, maintain spinal perfusion, and potentially treat them with gentle patient handling. And many of these patients have multiple other injuries, which means that you can't look after their blood pressure, you can't maintain spinal perfusion because they're bleeding to death because they've got a liver injury or spleen injury or a horrible chest injury. So very, very few patients, the message is, have isolated spinal injuries, and it's only really the isolated spinal injuries which will benefit from an extrication technique based on absolute movement minimization. Key message, that was meant to be an S rather than a D, apologies. There is an excess death associated with extrication with patients who are trapped. These patients have many time-dependent injuries and many injuries. There is a low rate of unstable spinal injuries, which might be complicated by minor movements. Old folks do much worse. And because of these things, getting it right will, or at least should, make a difference. So by perhaps minimizing entrapment time, by looking after our patients well, by getting them out quickly into the appropriate centre quickly, we may be able to affect this excess mortality and get to the point that trapped and untrapped patients are more equal in their outcomes. So we've done part one of what I promised, and we've looked at time critical and spinal injuries and their frequency. And definitely, I hope you may have known this already, but hopefully what you've heard today, I mean, it definitely challenges some of the paradigms that we've based some of our extrication knowledge on. What we're going to talk about now are patients, which are of course important, because patients is what it's all about. And what we did with this piece of research is that we We recruited patients. Some of them had spinal injuries, some of them didn't, who had had a motor vehicle collision, which had resulted in injury, and they'd been extricated. And we used a technique of semi-structured interviews delivered by a trained psychologist to interview these patients and ask them what it was like and what we'd done well. And so we, rescue services as a whole, and perhaps areas where we could do better. And kind of going into this, I thought things like, noise would be an issue, and pain would be an issue, and temperature would be an issue. But actually, what came out of this, what was important to the patients, was quite different from what I'd kind of guessed in advance was being an issue. I think the first important thing to say is that this was a major life event for all of those involved. And I do about a shift a week on air ambulance. So and half of what we do is road traffic collisions. So I see a lot of people who are entrapped, and it's part of my day-to-day life. For most people, this is a major life event, and the level of post-traumatic stress disorder, the level of kind of psychological shock, the issues they have afterwards are really quite significant. And I think it's really more important we remember and reflect on that when we're considering our approach to these patients. And many of them have distorted memories of the events and periods of time where time seems to be going very quickly, and periods of time where time seems to be going very slowly. And there's definitely a speech mark shock phase immediately following impact, where a vast majority of the patients, they didn't feel pain. They were able to move. They felt that perhaps they would be able to self-extricate. And then over time, kind of things normalized, and perhaps they came out of that shock phase and then kind of started to realize the extent of their injuries. But there's definitely seems to be this window where pain isn't such an issue, but they are shocked. And some people describe kind of being completely vacant and away from it all, whereas some people have got relatively clear injuries with a kind of a different time perspective than we'd expect on that initial experience. Very variable pain experience. Pain wasn't as significant in these patients' journeys as I thought it would be. It doesn't seem to be a huge issue when people remain entrapped, but they do experience kind of almost more pain as that shock and adrenaline-driven phase kind of dissipates, and they're very keen to get analgesia once they're extricated, and that needs to be done promptly and quickly. The strongest theme, perhaps I should have put it at the top, but it kind of seemed to fit in here, was communication and companionship. And some of the patients described being treated almost like a sack of potatoes, or like a non-living being, whilst people hummed and did their jobs and talked over them and didn't really understand what was going on. And they were really scared and frightened as a result of that. And some patients describe someone sat next to them in the driver's seat, telling them what's going on, communicating with them, perhaps holding their hand, telling them what the next stage of extrication was going to be. And the strength that the patients get from that came out so strongly in the interviews that it's something that will definitely be a recommendation, to make sure that someone's talking to them as like a person, someone's explaining what's happening, and ideally someone's being their companion in the vehicle with them. And I think that probably needs to be someone they can see, as opposed to someone kind of sat behind them holding their head on. So do think about that. It did seem to make a massive difference to the patients that we spoke to. Communication with family was tricky, and many families felt out of the loop, unable to speak to their loved one, unable to find out what was going on, getting lots of closed feedback. Oh, sorry, we can't reveal that. Sorry, we can't tell you what's going on. You'll have to come back later. Patients being transported to hospital with no one knowing who they are, so not knowing which hospital they've gone to, or even if they've been in an accident, and that came through strongly as well. One thing which really surprised me was the negative effects of photos and social media. So a lot of people described ongoing distress from seeing photos of their broken vehicle, either on fire and rescue service Facebook profiles, or reported in their local regional newspaper. There was a lot of negative stuff around social media and their families finding out through social media about their accidents. And then also the negative effects of kind of people, I'd say kind of like interested well-wishers approaching them through so finding out through social media that they'd been involved in a nasty accident, and then kind of people who didn't really have any connection with them, or long lost people, reaching out to them and saying, oh, no, I was at primary school with you, we've not spoken for 45 years, but I'd really like to know what happened in your accident. And people reported this with surprising regularity, and it certainly made me stop and think about how we communicate post-accident with the family, and what we should be doing about this as a group of rescue and clinical professionals. It's interesting, on the sides of the fire trucks in Germany, they have a really large printed QR code, which when you hold up your phone to it, if you're taking photos of the scene, it effectively takes you to a link which says, what are you up to? Please don't do this. It's intrusive and horrible for the families. Please stop it. And I think that's something that we could think about, whether it be a QR code or having someone allocated to that on scene. And also, I think we can reflect about how we report these on our own social media channels, whether it be photos of the vehicles or other aspects of this care. Rebecca Lund, thank you for that in the chat. Yeah, I think that is a very common theme, that people have very nasty injuries and at first didn't realise the extent of those injuries. And I think my take from that is, I think if you're on scene within the first few minutes, there's probably a window of opportunity to extricate these patients, where you perhaps need to think less about analgesia and more about rapid extrication. And probably the harm benefit is different from someone who's been stuck in the car for an hour, scared and frightened and cold, and has got to grips with the situation more. So we've talked about time critical injuries and spinal injuries. We've talked about our patients, and the last bit of this is talking about some of the extrication work that I've done in terms of biomechanical studies with some of the folk on this call, and we'll just run through that quickly. So all these biomechanical analyses are done the same way. So they use a 3D computer. They use healthy volunteers strapped up with motion sensors, effectively very similar to the techniques used in computer aided graphics for video games and for films, so that we can replicate human movement. And you'll see some of those videos in a bit. And effectively what we can do then is look at movement at the particularly the cervical spine, but also lumbar spine, and try and work out what's going on. If you want to look at one of our publications, once again, it's free and open access. You can hold your phone to the screen and this will take you to the link. Please have a read. I hope you find it useful. Once again, it's got a horrible long title. But this looked at 4 groups of patients. So what we did is we took patients, one group got a collar and instructions, one group got a collar and no instructions, one group got no collar and instructions, and one group got no collar and no instructions. And we looked at self-extrication from a vehicle. I'm hoping this plays. It might play. Does it play? Yeah, so this is an example of the 3D models that we can render from this. And we've done this many thousands of times across probably now hundreds of volunteers. So we've got a fair idea what people are like and what people's movements are like with that. Yeah, that's just playing again, apologies. So this is our findings effectively. Sorry, it's probably very small on the screen. But this is looking at AP movement, so forward, backward movement at the cervical spine, and no instructions with collar is this small one. With instructions with collar is this other small one. No instructions, no collar comes out here, and with instructions, no collar is around about here. So effectively, if you've not got a collar, then you should give a patient instructions on how to leave the vehicle safely. If you have got a collar, actually, with instructions, seem to make things slightly worse. If you look at all the movements, so we looked at many movements, including forward, backward, side to side, rotational movements, both at the cervical spine and the lumbar spine. So effectively, collars do make quite a significant difference to movement, and that may or may not be important, but if you're looking to minimize movement, a collar is useful in minimizing movement during self-extrication. The next piece of work, and I just need to be clear that this is a waiting publication. I'm hoping it's going to be published. It's done to the same standards and has found some interesting things. And I'm hoping that will be out by Christmas. But at the moment, it hasn't been through a peer review process, unlike the other publications that we've talked about. So this is a video. I think this chap it all looks a bit odd because there is no car. So this patient is coming out with a roof off type extrication. So you can see that the seat has been wound back and he's been dropped down in the seat. And now he's being gently lifted up. You can't see the spinal board either, of course, but I presume he's had a little wiggle and he's now been lifted up onto the spinal board. And then you can see that he's been moved again up and down and then lay down flat, at which point the experiments ended. And you can see just at the end there, all the participants for some reason wanted to cross their legs the moment they get laid down flat on the ground. I don't know why that is, but yeah. So this is what we found off. So at the top here is roof off extrication. Here is a B post rip type extrication. Here is a rapid extrication, which for the purpose of this involved opening the door, leaning heavily against it. These are all drivers which are extricated, leaning heavily against it, and then putting a spinal board effectively under the driver's bottom, so no cutting at all, rotating them out gently with a 3 or 4 person crew, then lifting them up the board and taking them away. And at the bottom here is self-extrication. These bars here are what are called confidence intervals or 95% confidence intervals. So even though Rapid X looks like it takes more movement than roof off, the distance difference is very small if you look at the means, which is the average, but also importantly, these 95% confidence intervals cross. So statistically, you can say that these types of techniques are all about the same, and the self-X in terms of spinal movement is quite noticeably better. And all the movements you look at, whether they be across the cervical or the lumbar spine, I could show you 20 graphs and they all look like this or very, very similar to this, with roof off, B post rip and rapid extrication generating similar amounts of movements. Bearing in mind that roof off extrication, when we've looked at this prospectively, takes an average kind of 32 minutes, with these techniques being B post rip and rapid X being much, much quicker, and self X being the quickest of all. So if you're choosing one of these techniques based on their movement minimization ability, then roof off, B post rip and rapid X seem to be very much the same, with self extrication, if you can offer this to any patient, being the best route biomechanically, as well as being the quickest route. So I've been talking for 46 minutes now, it says, so we're coming towards the end. So we've talked a bit about decision-making complexity, and we've talked about how we've moved in time through being effectively told what to do, to realizing that our patients are complex and that the rules that we're given, or sometimes the algorithms that we're given, don't do justice to the patients in front of us. Unfortunately, that complex decision-making machine is you, and is your clinical acumen and your clinical training, and that should be our focus in supporting clinical and fire and rescue professionals in making the right decisions for their patients around them, rather than confining them to binary decisions or algorithmic decision-making purposes. I can't give you all the information about every aspect of extrication, which is going to help inform these decisions, but hopefully we've touched on something around time critical and spinal injuries, something around what our patients want, and some stuff we've learned about extrication, which might be useful in you you finding that clarity. This is the studies that we've been doing effectively, and this is more formally laid out and less related to decision making complexity. But we've completed a series of studies looking at injuries, morbidity, and mortality, looking at some of the data that we've looked at there. We've looked at some studies looking at extrication, and one of the ones we've not studied is one of the ones we've not discussed today, but we have done is around chain cabling type extrication or Scandinavian extrication. And we've collected new data on patient experience of extrication. All this is going into what's called a Delphian consensus type process, which is supported by UCRO, the National Fire Chiefs Council, and the College of Paramedics, and the Faculty of Pre-Hospital Emergency Care, and the British Association of Spinal Surgeons, and all sorts of, and some charities which look after people with spinal injuries to make sure the patient voice is represented as well. And effectively, what we're hoping is that we're going to combine some of the information that we've gathered over the last few years with all the other data. And obviously, there's lots of high quality data out there, and bring that into some guidance, which hopefully will help with some of the decision making and complexity, and not hinder with some of the decision making and complexity. So I've seen there a question from Jamie Barkley, which is a very good question, which is around have we looked at spinal movement at collar application? Yes, we have. I've not gone into that data today. It's a couple of millimeters, and effectively the spinal movement associated with collar application is much less than any of the movements that we looked at. So therefore, it makes sense to apply a collar and take that 1 or 2 millimeters of movement, because it saves much more movement later on in the extrication phase. And that takes into account whether you look at maximal movement as your outcome, or whether you look at something called travel as your outcome, which is total movement. So we've talked about these things today. These are my personal views, which kind of based on what I've learned and what I've experienced, and the conversations I've had with patients and other clinicians. So it's all about the patients, and they can often help. They can actually probably diagnose their injuries once they're outside that acute shock phase almost better than we can. And they can probably give you a very good indication about whether they are in a position to self-extricate or not. Tell them what's going on, ask them for help, and they will be able to help guide you in what's feasible in their route of extrication. Decision making is complex and requires expertise, and extrication is complex and requires expertise, particularly when this patient is entangled in the wreckage. We've talked about patients who can be extricated without disentanglement. If you've got an entangled patient in a modern vehicle, the transfer of energy there is huge, and this patient needs fire and rescue and clinical expertise, and they need an absolute minimum amount of time in the car, because that patient is likely to be very seriously injured. The historical paradigms of extrication are probably incorrect. The whys of extrication, so we're doing extrication to minimize movement based on the propensity of spinal injury. Spinal injury is actually quite rare. Unstable injury is even rarer. Unstable injury without other time critical injuries is even rarer. So that kind of putting spinal injury on a pedestal and basing our extrication around that's probably a failed paradigm, which now we can probably move on from. And also some of the paradigms around techniques. So for example, and the nomenclature is different from region to region. So a type A extrication or roof off extrication is somehow better and associated with less movement than a self extrication, or a rapid extrication is probably incorrect. And probably once you take into account the times and what that means if you're bleeding to death, I know I would always choose the quickest route of egress for my patients. Many of the clinical paradigms that we teach are also incorrect, and actually identifying sick patients is really difficult. Their clinical observations aren't particularly useful, and I would challenge really if they're actually going to inform what you do from an extrication process. And we've done another piece of work actually, which shows kind of every time you go in to check for observations, every time there is a patient check, it adds about 8 to 10 minutes onto a patient's extrication. So I would interpret, if the observations are really bad, the patient's really sick. If the observation's really good, then like one of my colleagues said in the chat, compensate, crash. It doesn't really tell you anything. My advice would be always take the quickest route, and that's normally self-ex. And many patients with multiple injuries can self-extricate with a small amount of support. And they can, and we've seen that with patients with multiple spinal injuries, chest injuries, pelvic injuries, all being able to self-extricate from the vehicle. And the soft skills, including intra and post extrication, are really, really important. So how we talk to our patients, keeping them warm, tell them what's going on, inform them what we're up to, but then also importantly afterwards, how we engage with the families, having to think about what we put on social media. All that is really, really important to our patients and their long-term trauma, not just in terms of their physical trauma, but their psychological trauma as well. So we've talked a lot about extrication, and we've talked a bit about decision making and complexity. I hope that's been useful. There's, I think, kind of 5 to 10 minutes now where we can have a conversation. I'm very happy to answer any questions. I really find these forums really useful, both in terms of organising my thoughts, but also in terms of getting feedback from people and getting their really valuable perspectives on the work that we've done, and also what's missing and what else is needed to change people's minds or to move people forward. So I hope you found it useful. I hope you found it moderately engaging. Let's have some questions. Excellent. Can you still hear me?
Yeah, we can hear you nice and clear.
Yeah. So the first question is, given the very low number of unstable spinal fractures and the opportunity cost of delayed extrication, is there any evidence that traditional extrication techniques actually have any more morbidity or mortality benefit? And the answer to that is no. So the extrication techniques evolved in the 60s and 70s. They evolved from different parts of the country and different parts of the world. We're doing very different things. Techniques evolved from considered best practice, but they were never studied as you would study a new medical technique. And there's actually a really nice analysis from the late 60s on extrication techniques from the US, from Washington, commissioned by a government department. And it says effectively, the patient should come out rapidly, and formal extrication techniques are only required if there's evidence of intrusion in the vehicle. And things go round in circles, and I think we're probably back to there again. Once your patient is self-extricated, plus or minus collar, do we have evidence of the best way to load them onto trolley cots? So I think patients can tell you this if they're conscious, and put them into a position of comfort. For many patients, that won't be on spinal board. If you get an opportunity, Google the lateral trauma position. There's lots of good work on the biomechanics of that. Patients seem to find it more comfortable, and it does a good job of looking after the spine. In terms of my personal technique, I'll put the collar on for the extrication itself and then take it off once the patient's kind of in a position of comfort on the trolley. If I take the collar off and the patient goes, "Oh, that felt really nice," and they've probably got a spinal fracture, so I put it back on because they're probably benefiting from that small amount of support. If on side or on roof, what would you suggest to safely remove patient? So we've done some work around this, and really interestingly, so patients on when the vehicle is on the side or on the roof come out much more quickly than is the patient if the vehicle's on all four wheels, which when I started the research wasn't what I was expecting. And I think this is because when you look at fire and rescue services training, a lot of it, because of the limited amount of training time and the limited amount of vehicles available, a lot of the training takes place with vehicle on four wheels, and that's understandable because that's the most common presentation. What tends to happen is the vehicle's on the side or it's on the roof, people kind of develop a bespoke extrication for that patient in that vehicle with all the complexity that we talked about. And that is what I'd advise is, I can't tell you with this on his side because of all those things: patient availability of resources, cutting ability, experience of team, the size of your crew, the kit that you've got, all that sort of stuff is going to make a difference. But if you do if you've got knowledge and expertise and apply it to that patient and to that extrication, you will come up with the technique which works best at the time, rather than being didactic in use one or another. So elephant in the room regarding litigation, yes. So if you look at the litigation literature around pre-hospital care, it's very, very limited. There's been a couple of cases. There's been more in the States, as you'd expect, but only a couple in this country. And they're normally related to what we'd all consider bad practice. So it's not being gentle patient handling. It's being allowing a patient to fall from a height, or to fall off the back of a sofa, or to fall down a set of stairs, who've had a spinal injury, and that's been made worse. So I think litigation sits over all of us. We need to take it seriously, but it probably scares us too much. But also to support people in their practice, which is why we need to produce the guidelines that we're talking about. So I'm hoping that the guidelines which are going to drop out of that study process will allow you the freedom of practice within some kind of carefully crafted kind of enabling boundaries to deliver the best care for your patients, rather than a strict algorithm or a strict you must do this or must not do that. And once that becomes best practice, not best practice, once that becomes established practice, then that becomes reasonable practice. And then if you look at the what you need in order to be considered negligent, you need to do you need to do something which definitely isn't regarded as reasonable practice by a minimum number of healthcare professionals. So I think you could very easily make the argument now and you could very easily defend yourself now, because conversations like this are happening kind of all over the country. And I've seen very lots of recently kind of enabling protocols and guidance. So I think you can make it now, but I'm hoping we can strengthen this by working with all the partners that we've described.